Good morning, and congratulations. You're halfway through the last day, almost. Yeah, so my, ooh, goodness, my assignment here, you notice in the topic, in the book, it says it's prevalence of ARDS. You notice I've changed my name to epidemiology of ARDS, and you'll see why. I have nothing to disclose about this topic. So, an epidemiology reminder. I know everyone heard this in medical school and residency and fellowship, and not everyone works with this every day. This happens to be some of the stuff that I play around in all the time, but not everyone is reminded of this all the time. So I just want you to think about the difference between incidence and prevalence. Incidence is a rate of onset. How fast do cases accumulate? How quickly do they come in? How quickly do they see them? It's like the number of cases per unit of time, just like miles per hour, or forgive me, it's Canada, just like kilometers per hour. How rapidly are the cases coming? Now we have to correct for number of people because if you live in, say, Niagara-on-the-Lake, the number of people coming into your hospital with ARDS may be smaller than coming into the University of Toronto Hospital, but if you correct for the number per a set amount of people, and usually we use 100,000 for this epidemiology, then you can compare apples to apples that way. So we generally do cases per time per person, and that's what incidence is. And now there's an incidence per population, so we use per 100,000 population, and then there is an incidence per facility. How many patients come into our hospital per year? How many patients are admitted to a hospital bed per year or an ICU bed per year in our facility? And why that's important is because the epidemiology of ARDS is a mixed bag. And every different study tends to look at it a little bit differently. Now we're going to try and cull some of the better things so that we have good evidence on which to base our discussions. Prevalence, on the other hand, is a proportion. Prevalence means something like this. Of the Halloween candy we have now, what proportion or percentage is candy corn? Yuck. I don't like that stuff. So that is the prevalence of candy corn in my Halloween candy bag. Now, sometimes we do something called a period prevalence, which smacks of incidence, smells a little like incidence, but we may pick a period of, say, 4 weeks and say, okay, because we know ARDS fluctuates up and down and how it comes into our facility in 4 weeks, so we pick a period of 4 weeks and we say, what proportion of the people that came in that 4 weeks had ARDS? Just so we can capture enough for discussion. We don't consider that an incidence. We don't try and extrapolate that beyond where we are. Okay, like I say, I tell you all that stuff because the epidemiology of ARDS is a mixed bag. And I've divided it into epidemiology before Berlin and epidemiology after Berlin. So just to remind you, the Berlin definition did a few things that were important. We used to say, according to the American European Consensus Conference definition, that onset had to be acute. We've now defined acute, so we can be more precise about what we're talking about. Bilateral infiltrates on a frontal chest radiograph has changed to bilateral opacities or computed tomography that aren't fully explained by a fusion at back on. Can you hear in the back? Kind of. Thank you. All right, leave it to my buddy Andy to have an answer. Okay, let's try this again. So essentially what the Berlin definition did was take some of the things that were a little bit diffuse of our American European Consensus Conference definition and make them more specific in hopes that this would help us to study the disease process better. A fascinating thing now that I've gotten more into area under the ROC curve, or receiver operator characteristic curve, fascinating to know that as far as predicting mortality, we're really not that much better off with our current definition. Anything in the range of 0.5 and hasn't even reached 0.6 yet, we consider pretty much to be a worthless test as far as predictive ability. So that's okay. We have a more specific diagnostic approach. So let's talk about our epidemiology. Pre-Berlin, a few things that are important looking at it from this direction. This is data from the lung injury prediction score evaluation, a prospective observational trial where they looked at people with known risk factors for ARDS. This was, again, remember, pre-Berlin. Known risk factors for ARDS to look at what proportion of those people coming into multiple ICUs in multiple locations would ultimately develop ARDS. So you can see shock is at the top of the list, no surprise there. Aspiration also very near the top of the list. 17, 18% of people who have those things will go on to develop ARDS. And then the whole list all the way down through pneumonia, emergency surgery, et cetera. Sepsis on this particular table got lumped into shock. Sepsis, as we know, has been one of the major risk factors, or was one of the major risk factors at least once upon a time. A few risk modifiers. The only one I want to really mention is diabetes, because I'm fascinated by this and I don't have a good biological explanation, but if you have diabetes and get sepsis, you're less likely to get ARDS than if you don't have diabetes. Again, I have no biological explanation for that, but it's true. But a lot of other risk factors that you know might portend worse, or you have an inkling might portend worse, such as obesity, hypoalbuminemia, or high FiO2s. Yes, indeed, they have an increased risk of developing ARDS. So before Berlin, we have some population-based studies. And I think that's kind of what we're probably mostly interested in, is population-based studies. This is one of the best ones of the pre-Berlin era. It's by Gordon Rubenfeld when he was at University of Washington in Seattle. It was a population-based study, meaning every patient in Kings County, Washington was observed over the course of 12 consecutive months in 1999 to 2000. That's all 21 hospitals in and around Kings County, Washington. They screened everybody who's receiving mechanical ventilation for ARDS according to the previous consensus criteria. Let's see, I'll just go over here to talk about numbers. They found 1,113 cases of acute lung injury. 74% of those cases, or 828, were ARDS. The crude incidence, and this is going to be important because I'm going to highlight this a bit. The crude incidence was 58.7 for ARDS itself, 58.7 cases per 100,000 people per year. Extrapolated to the entire United States population, that would mean about 100, oops, I'm going the wrong direction. That would mean about 141,000 cases per year of ARDS in the US. And so that was probably our good estimate at the time. Population-based study. If you're going to do population-based epidemiology, you have to find some population and capture all of it, and that's exactly what Gordon and his colleagues did. From Europe, the equivalent study was done in Spain called the Alien study and published in 2011, again using pre-Berlin criteria, observational, population-based, 17 hospitals covering 13 geographic regions in Spain, but received all admissions of mechanically ventilated patients during that period of time. That was between 2008 and 2009. All ICU patients were screened, all according to AECC criteria. They had 11,000 admissions, 3,400 mechanically ventilated patients, ARDS in 255, and that comes out to 7.2 per 100,000 per year. Now that's interesting. So if we back up, Gordon's study said in the United States 58.7 per 100,000 per year. In point of fact, prior to Gordon's study, the administrative criteria-based epidemiology had also suggested somewhere in the range of 70 to 80 per 100,000 per year in the United States. In fact, every epidemiological study that's ever been done in the United States suggests that proportion. Every epidemiological study, including these carefully population-based studies in Europe, have demonstrated a substantially lower rate or incidence in the population. So that's interesting. Now, at the Mayo Clinic, as you know, they're interested in, are there things we can do to modify the risk for ARDS? And probably part of how they got interested in that is this longitudinal study done in Olmsted County, Minnesota. As you know, there's a small hospital there that is interested in epidemiology in that county. It's called the Mayo Clinic. What they found was at about 2000, in about the year 2001, we had a population-based estimate of about 80 per 100,000 per year, but that began to decrease over the years down to about 39 per 100,000 per year by 2008. Interesting. They wanted to understand, why is this going on? They split it out between community-based ARDS versus hospital-acquired ARDS. And here we've shown community-based on the left, which suggests there's no real pattern. And how they defined that is as people who had ARDS within 6 hours of reaching the hospital. So people who essentially came with ARDS, no real pattern there to see, but people who acquire their ARDS after being admitted to the hospital, I don't know why I'm leaning into this microphone, by the way, since it's not working. People who acquired their ARDS in the hospital accounted for all of the decrease in incidence. So this is interesting. And so I put up this graph. It may be a little hard for you to read the things on the right, but they go down the list here looking at what did we do differently during that period of time. Well, we changed how we transfuse people, how often we do it, and the kinds of things that we filter out of the transfused blood products when we do it. With regards to mechanical ventilation, we have demonstrated that we've reduced our tidal volumes from 10.6 on average in 2001 to 6.8 in 2008. We have had a sepsis program that reduces the number of people that go into septic shock and improves the mortality of our septic shock patients. We have inpatient pneumonia care is improved. We have intensivist staffing now 24/7. We didn't have that before. We have a rapid response team that came into being, and we got our electronic medical record, and for what that's worth, I'm not sure whether ours has really contributed to improved patient care yet. I say yet, I think it's going to, but nevertheless, these are the things they think they did. Now, you can't prove that these things had an effect because this is an observational study, of course, but it is highly suggested that things that we have learned and done in the early 2000s may have made a difference. So in the pre-era, in every study performed by any means of estimating population incidence of ARDS is an order of magnitude higher in the US compared with Europe. Why? I don't know. Hospital incidence seems to be declining, and that may be because of better care for at-risk conditions. Now, post-Berlin, in the Berlin era, we have exactly one epidemiologic study of major significance, and it's called the LungSafe study. And I'm only talking about the first category here, epidemiology of people with ARDS, and I'm leaving it to my colleagues to discuss the other important components here. It's an observational study. Hospitals in 50 countries around the globe, 5 continents, all but Africa and Antarctica. Would have been cool to have some people from Antarctica, but I don't think they'd think it's cool to have ARDS in Antarctica. So 459 ICUs, 4 consecutive weeks during the winter of 2014 in North America. That meant between February and March. In the southern hemisphere, that meant between June and August. It's ICU-centric, not hospital or population. So the numbers we get out of this will tell us things about what to expect in an ICU and not what the actual incidence globally of ARDS is among the population. They didn't have population data for every locale, or at least they didn't apparently try to collect it. Every ICU admission was enrolled and followed, and they used the Berlin criteria for ARDS. What did they find? In those 50 hospitals over 4 weeks, 3,022 patients with ARDS. I'm going to skip past the next two lines, if I could get an arrow. Just go down here. Your mean age is 61.5. That's about the same as what we were looking at with previous epidemiology. Women are only about 40% of that. So men are 60%, slightly over. The mean height, though, I find fascinating. It was 5 foot 6 inches tall, which seems kind of, I don't know, maybe that is globally what we should expect. And the mean weight was 78 kilograms. So out of 13,500 mechanically ventilated patients, 13,000 had complete data, 3,000 had ARDS. They accounted for 10.4% of ICU admissions in the study, or in mechanically ventilated people, almost a quarter of mechanically ventilated people in this study had ARDS, had or developed ARDS. What that equates to for an incidence at the ICU level is roughly 0.4 patients per ICU bed per a 4-week period. So let me just summarize all of this that we have. We have no population-based incidence data since the change to the Berlin criteria. But we do have what we know from previously. The expected number of cases in an ICU around the globe is about 4 per month for a 10-bed ICU. So just multiply by how many beds you have, and you should know about what you should expect to see if you, in fact, detect it, which I think is Dee's topic here. There is a mysterious 5 to 10-fold difference in population-based incidence between Europe and the United States that we still don't really understand, and the incidence may be declining, at least for hospital-acquired ARDS. Thank you very much, and I'll turn it back over to Andy.
Thanks, Steve. I think we have time for one question, if there's any in the audience. If not, Steve, I know you don't know the answer to this, but it's really intriguing that there is a difference, maybe a difference between Europe and North America. Is there any suggestion that the Europeans were implementing more effectively evidence-based practice before North Americans were better at transfusions, better at ventilation, to explain some of that difference?
Yeah, that's a good question. And as he said when he prefaced it, that I know you don't know the answer to that. I really don't. However, by the way, I will say on an ICU basis, I should have broken this out, and if I had been very smart, I would have. US and Europe are much closer in terms of number of patients per ICU bed per that 4-week period. So it may be that if we get some population-based epidemiology based on Berlin and based on better detection techniques, that we might get an answer there. What I will say about that, by the way, is that Europe has far fewer ICU beds than the US, and it may be that that's why we see more, because it may be that some people don't even get to the ICUs in Europe.
Thank you, Steve.